Hello, my name is Jane Leicester. I work with the MND Care Centre based at Salford Royal. I've got a post that's funded by the MND Association, which has the aim of looking at the pathways of care for people with MND and how we can improve care and better support people. I'm going to introduce the webinar today, and I will just start off by talking about what our aims are. So we want to start the conversation off to ensure that all people with MND receive the correct advice throughout their journey, and provide some guidance around advice for patients with regards to breathing, nutrition and swallow. So for people that is aimed at all healthcare professions. So today I'm going to give an update on the guidelines for MND and an overview of the current service. And then my colleagues are going to give some guidance on the early management of breathing, cough and recognition of respiratory failure for someone living with MND, and guidance on the nutrition and swallowing management for people with MND. So we currently, this is to gives you an overview of the Salford service as it stands. We have a caseload of approximately 250 patients. Not all of whom are in Greater Manchester, some are outside Greater Manchester. But the bottom left-hand corner of the screen sort of gives a rough breakdown of where all the patients are at any one time, and it varies. Sometimes we'll have a few new patients in one area, and we find the caseload will go up or down accordingly. So just when someone's newly diagnosed, they first come to a new patient clinic at Salford Royal, where they meet the consultant and the specialist nurses. They're given the diagnosis and they're given some basic information about how to contact the MND Association and first information. But that appointment's often the patients are very shocked because they're often not expecting, and it can be quite a distressing appointment for the patients at that point. So then 2 or 3 weeks on after that, they would have an appointment with the multidisciplinary team. And that would consist of seeing the speech therapist and the dietitian, the physiotherapist, the occupational therapist, and ideally the social worker, although we don't currently have one in post. So at that appointment, the patients would be given sort of initial advice, initial management advice, and an assessment to pick up if there's anything urgent that needs to be dealt with or addressed. From there, they're then referred to the 12 community teams, and going forward from then, the care is shared between the community teams and the care centre. You don't need to look at this picture is very busy, very complex, but it just gives an overview of the model of care for motor neuron disease in Greater Manchester. And I think it really, I can share this with people if they haven't already seen it or don't have a copy, but it really just highlights the complexity of this condition. It covers so many different biological systems, so many different professions are involved, and it is an incredibly complex process, which actually makes it very difficult to navigate, both for the patients and for the staff as well. So our service vision is that for all people living with MND, we should receive the right care at the right time. And for all people living with MND to receive equitable service regardless of where they live across Greater Manchester. Also for them to receive evidence-based care as defined in NICE Guideline 42 and in line with the more recent research, such as the PROGAS study, which we'll go into again. And to provide care in line with the Northwest model of care for life-limiting conditions, which I will also come back to. We also want all people living with MND to have access to research opportunities. And I'll perhaps take this opportunity now to say that there are formalised research projects happening within Salford, and many of the patients are on those programmes. But we're also really keen to to get involved in research programs within the community services as well. And there are people within the care centre who are keen to support some of those research initiatives. So if you've got ideas or thoughts about research, or if you're doing an MSc and you just got a nice little project that you've got in mind, we'd love to talk to you about it a little bit more, because as I say, there are people who are there and ready to support. So come along and have a conversation with us. That would be really good. I'm going to move my picture. I don't know whether it shows up on yours so that you can see that a bit more effectively. So the guidelines that we are working towards are the NICE Guideline 42, which was first published in 2016 and then updated again in 2019, and it covers the whole journey for MND from diagnosis through to death. But it also covers all areas of care that would be provided by all the different professionals along the way, and what you would expect each professional to be providing. But also we want to include some more recent research, which is sort of post-NICE guideline really, such as the PROGAS study. And we also have more recently a model of care for life-limiting conditions, which has been published. I will just show you that now, and it is a personalised care and support plan for people with life-limiting conditions. So it follows the journey really through from when the condition is stable to declining, through to death, and then to the support after death and bereavement support for families. And it gives out guidance about what you should be doing at each stage of the journey, which is important. We want to make sure that that aligns with the NICE guidelines, so that, because it particularly brings in some of the community and primary care services, so such as ensuring that the patient's on the gold standard framework list for a local GP practice. So we particularly want to make sure that those line up with each other. So we want for all people living with MND to receive an equitable service regardless of where they live across Greater Manchester. There are variations in provision of service due to differences in commissioning. We see, as I mentioned already, we've got 12 different community services, and they all work very differently. We've got some of them that commission differently. They have different referral criteria for different services. So some of the examples I've mentioned here: dietetics, orthotics, wheelchair services, continuing healthcare, vocational rehab, seating, and many more as well. And I think because we see all the patients in one place, coming in from all those different areas, we see that patient A can get something in one place, whereas patient B can't get the same thing in another borough. And there's quite a lot of variability. And there are also variations in care related to the capacity of the teams, which is often related to the staffing levels within teams. So that can result in differences in care. So in some areas, patients may be discharged from the services, where in others, they would always stay under regular review. And again, those are variations that we see. Want to ensure that all people living with MND receive evidence-based practice as defined in the NICE guidelines and in line with the more recent research. So we want to aim to have an agreed programme of care that will be provided either by the care centre, the community team, or both groups. There are certain things that we know ought to be provided, and because not all patients come to the multidisciplinary team multidisciplinary clinic appointment, sometimes because they're already known to the community team, sometimes they're not well enough, sometimes they decline. So if they don't come to that appointment, there may be elements of care and advice that they're not given, and we want to make sure that if that's the case, then that they receive that advice from the community team, and so that they don't miss out on those opportunities and guidance that might benefit them. But we need to agree what that is. And some elements of care are better if they can be reinforced. So maybe the care centre staff may tell them about it, but then the community team can reinforce that information as well. But in order to do that, we also need an effective communication and recording system so that we can ensure that the basic standard elements of care are being provided. So examples include teaching breath stacking, offering voice banking, early nutritional advice, high calorie diet. And if we need to find some way of ensuring that those patients have been given all that advice and that they've not slipped through the net and not heard anything about it, and maybe discover about voice banking at the point when it's too late, for example. So today we want to start the conversation by focusing on two particular areas of care, which will be covered by the next speakers. And at the end of the session, we're really happy to have questions and to hear people's ideas and thoughts, and we'll really welcome people's suggestions. So I'll say thank you for now and goodbye, and then speak to you again at the end of the meeting. Thank you.
Hi everyone, my name is Dave Derry. I'm lead physiotherapist for the North West Ventilation Service at Wythenshawe Hospital. Thank you for listening to this talk today. It's been a pleasure to speak to you guys. If you have, I am recording this, so if you have got any questions, please do feel free to email me. I'll provide my email details to you at the end of the presentation, or you can get them from the organisers as well too. So I'm just going to share my screen with you now. This might just take a few seconds to do that, so just bear with me. Okay, and I'll just get the slideshow started now. Okay, so some aims from today's session. We're going to identify the early signs and symptoms of respiratory compromise in MND patients. And thinking about community, we're going to look at the assessment techniques which you could do within the community setting, and any potential early interventions that you might be able to do to manage breathing problems with those patients. I'll also discuss how MND impacts upon a patient's ability to cough and clear secretions effectively, and then we'll talk through some strategies which we can use to assess a patient with MND's cough effort, and think about some early management strategies which we can use to improve patients with MND's cough effort as well too. So I'm going to cover the management of breathing to start off with. So just to set some background and some context, if you think about motor neuron disease will cause respiratory muscle weakness. And as a result of that, it will lead to a reduction in alveolar ventilation, and also some resultant atelectasis as a consequence of that. So we get the collapse of the alveoli here. We may well also get some sputum plugging as well too, as a consequence of the fact the patient's not breathing as deeply, they're not getting those secretions moving effectively. And coupled together with the fact that patients' cough effort might be impaired with patients who have motor neuron disease, it puts these patients at much higher risk of lower respiratory tract infections. And obviously all these factors combined, and the fact that the patient's muscle pumps are failing with the respiratory muscle weakness, it can lead to this respiratory dysfunction and ultimately respiratory failure. And that's been found to be the most frequent cause of mortality in motor neuron disease patient cohorts. Coupled together as well, as I'm sure you're all familiar, the NICE clinical guideline 42, which as I say, I'm sure you're all familiar with. And we'll talk in a little bit more detail about this later on during this presentation. It does provide direct clinical guidance of when and how to assess and monitor respiratory function, and it also makes recommendations as to the interventions which should be followed. So actually working in the community setting, you guys can start to follow some of this advice and guidelines, and you might be the key points of contact here. And that brings me on nicely to the fact that in terms of community team management, you are the key stakeholders in assessing these patients. If you're working within the community, you're likely to be seeing the patients with motor neuron disease much more frequently than the other services are, certainly from the regional tertiary centres such as Salford and ourselves at Wythenshawe. So you're actually in a really, really strong position to detect whether or not patients are starting to develop respiratory symptoms, and if they are, start to implement some management strategies or refer on to appropriate services. So talking about the early signs of respiratory failure, these are obviously some things that you can start to pick up. So I've mentioned about this reduction in vital capacity. So for those of you that aren't familiar with that term, vital capacity, it refers to the maximum amount of air that can be exhaled after a maximum inhalation. So because of the respiratory muscle weakness, which is frequently associated with motor neuron disease, patients can't take a sufficiently deep enough breath in. So thinking about symptoms that you might be able to detect, or that either they might mention to you, or you might see if you're doing interventions with those patients, or their relatives or carers may mention, or that they might be breathless at rest or exertion as well too. And frequently they might have difficulty lying flat as well. So thinking about if you were assessing functional transfers, for example, transferring on and off the bed, they might say, I'm really struggling when I lie flat, I need to be propped up. So that might give you an indication that potentially there's some signs of early respiratory signs of respiratory failure developing here, which could prompt onward referral onto an appropriate service. I've also mentioned about sleep disorder, breathing problems, and again, these might be something that your patients mention to you, or their relatives or carers mention. But a typical problem which is frequently happens when we start to develop respiratory failure are these early morning headaches. And these are related to high carbon dioxide levels and the body trying to flush out the carbon dioxide as best it can do. So it's a very common symptom that patients, when they start to have high CO2 levels, they complain of early morning headaches. And they also might say that they're quite sleepy during the daytime. They may well wake up feeling completely unrefreshed and feel like they could sleep, for days and days. So these are all sorts of signs that we would actually be looking for, that if you mention to your patients mention to you, they're starting to get some of these symptoms, then actually it gives you an idea, maybe they're starting to develop respiratory problems. Confusion and agitation can also be associated with high carbon dioxide levels as a result of respiratory failure. Although obviously I appreciate there will be a cohort of patients with motor neuron disease that do have frontal temporal dementia, and as a consequence of that, the confusion and agitation may well be caused by this. So that could be multifactorial here. Something else that we commonly see with some of our other patient cohort groups is nocturnal polyurea, so the increased frequency of urination overnight. It tends to be associated more with obstructive sleep apnea, and it's related to the increase in intrathoracic pressure caused by the collapse of the upper airway, and that causes release of hormones which affect the kidney, which then make the kidney excrete more sodium and water, and as a consequence of that, we tend to have increased frequency of urination overnight. But there are a degree of patients with bulbar motor neuron disease who do experience obstructive sleep apnea, so it can be a symptom that some patients with MND obviously do mention. But again, that can be multifactorial as well too. There can be other causes for that. But these, as I say, these are all sorts of things that you can be picking up at your assessment. You could be questioning, or patients' relatives or carers or themselves might be mentioning to you. Additionally, patients start to say that they're having difficulty managing oral secretions, or you notice that the patient is having lots of excessive oral secretions. Then again, this might be a sign that there's going to be some respiratory problems developing here. Frequently, that the excessive oral secretions will lead to pooling of saliva and sometimes mucus within the pharynx as well, which obviously then can tip into the trachea, and we can run the risk of aspiration pneumonias. So as I say, these are all sorts of areas that we can start to look at and identify as signs of early respiratory failure. So looking from an assessment point of view, as I mentioned earlier, in the community setting, you can make a really significant impact upon a respiratory assessment and look to see if there's any respiratory deterioration. And that's not necessarily from complex interventions. It's from your basic interventions that you might be doing on a day-to-day basis. Thinking about if you are trained in respiratory assessment and you're happy to do so, you could start to look and do a basic respiratory assessment on your patient. So obviously, if you train in auscultation, you could listen to their chest. You could palpate, have a look at the expansion. But actually, if you're not as familiar with respiratory assessment, look at the patient themselves, and you could actually see, do they look like their respiratory pattern has changed? Are they breathing quite shallowly? Are they breathing quite rapidly? Does it look like that the movement of the chest just isn't right, and perhaps you've noticed a subtle change since the last time you saw them? These are all subtle things that even if you're not trained in a full respiratory assessment, you can start to pick up, and ultimately you know your patients very well. And if that is the case, you can then start to think about some, some future interventions that you could refer the patients on for. A really nice way of looking at respiratory function and to see if there's any respiratory deterioration is functional activity assessments. So, for example, when you are mobilising the patient, are they breathless on exertion, more so than perhaps they were previously? If you're assessing transfers, are they more breathless on transfers than they were on a previous occasion? If you're assessing their swallowing, do you notice that actually when they're eating, they're really struggling because they're gasping for breath, and they're struggling to manage to eat effectively because of breathlessness? So these are all things that you can be picking up and you might notice those subtle deteriorations over periods of time. Another thing really is to think about questioning the symptom history that I mentioned earlier on. So when you go and see your patients or you speak to the relatives or the carers, do they have any of those symptoms that we've mentioned earlier on? So it's just to really sort of raise awareness of those symptoms, and then think about talking to the patient and asking them, questioning those or questioning their relatives, so that if they do have any of those symptoms, we can provide that onward referral here. So I guess really from the assessing respiratory deterioration, it's not that you have to do a full respiratory assessment as such on the patient. It's that you can start to notice those subtle changes that will make a significant difference to a patient's quality of life and ability to function within day-to-day activities. So looking at respiratory management interventions, obviously we are guided by NG42, and the key thing for this really is it specifies you should identify the problems and discuss these with patients. So from a respiratory perspective, we should be monitoring and assessing respiratory function and symptoms throughout the disease process. So both when they're diagnosed, at various points in the disease process, and also as they progress. In terms of sort of your role here, if you're noticing respiratory problems, there are some things that you can do, which we'll discuss briefly. But actually, if you're noticing that the patient's developing these symptoms, it's about the onward referral onto appropriate services. So whether that be the Motor Neurone Disease Centre at Salford Royal or the long-term ventilation team within Shore Hospital. And obviously what we can do with those is we can then start to complete some of the assessments which are recommended in the NG42 guideline. So in particular, we would be looking specifically at the low blood gases just to detect whether or not there is a raise in carbon dioxide seen, or alternatively, we might look to see if there's some metabolic compensation by an increase in bicarbonate, which would then make us think that potentially the patient's carbon dioxide levels are increasing overnight. We might need to think about setting them up onto non-invasive ventilation or discussing that intervention with them. I think really from a non-invasive ventilation point of view, it's around discussing the advantages and disadvantages to non-invasive ventilation to patients, so that they can make an informed decision, and discussing the fact that they may well become ventilator dependent in the long run as well. But obviously by having that information, they can make an informed decision here. Thinking about some of the interventions that they might do at the MND centre, they may well have some lung function tests, so including forced vital capacity, sniff nasal inspiratory pressure, and maximum inspiratory pressure and maximal expiratory pressure tests, which would assess the respiratory muscle strength to establish whether or not they are developing respiratory failure as well too from this perspective. So these are things that obviously can be done in the tertiary centre. But from a sort of grassroots level that you guys can provide, it's around supporting patients with functional activities. So for example, so mobility aids. So actually, if you can provide mobility aids, Zimmer frames, wheelchairs, etc., to allow the patient to do more with less effort, to try and manage some of the symptoms of breathlessness, that can obviously significantly help. Thinking about ADLs, so mattress variators, or hospital beds, so for example, so the patient doesn't have to lie flat or lay propped up in bed with pillows, they can do so in a comfortable manner. Thinking about modifying the patient's diets, so whether or not they need to be different textured diets, or whether or not we need to think about nutritional intake. So these are all things which you can maximise in the patient's home to try and improve their respiratory function within the limits of obviously what they can do as well. From an ADRT perspective, so the advanced decision to refuse treatment, you may be involved in this process, or you might be the person that starts to talk about an ADRT with the patient and make them aware of this as well too. If they've got an ADRT in place which specifically says, look, I don't want non-invasive ventilation, then that is absolutely fine, that is their right. However, it might be that now they've developed symptoms, they might change their mind. So you might be the person that says, although it says on your ADRT you don't want an IV, is this still the case? And it might be yes, they say, no, I don't want an IV. But equally, now they've got those symptoms, they might say, actually, I want to give it a try. So it's around thinking about, allowing the patient to make that informed decision with the ADRTs. And if they choose not to pursue the ventilation route and they are in respiratory failure, it would be around linking in with the palliative care team so that they can have appropriate support in end of life and appropriate symptom management relief towards the end of life. So again, these are many of the ways that you can actually make a significant difference to patients' respiratory function in the home environment. I'm just going to talk about siluria. I'm sorry, that's one word I can never pronounce properly, but hypersalivation. And as I'm sure you're all familiar with it, it's reported in around about 50% of all patients with motor neuron disease. And certainly there's a quarter of those that experience either moderate to severe symptoms. I think from a clinical perspective, I think one of the biggest problems is psychological, understandably, for the patients. It can be incredibly distressing, as I'm sure you're aware, for patients when they have got excessive secretions. From a psychological point of view, they may all feel embarrassed or ashamed by the fact they've got these secretions. They might not want to go out and be around people because they're so worried about having excessive secretions. It's in a few cases, it's incredibly sad. We've seen patients where they've actually come to the hospital with their mouth stuffed with tissues because they've got so many secretions in the mouth, and it's the only way of managing them for them. And obviously, from a clinical perspective, it's that leads to a potential aspiration risk. So again, it feeds into the fact that these patients are at an increased risk of lower respiratory tract infections and ultimately increased risk of mortality. From a ventilation perspective, obviously from my perspective, if patients have got lots and lots of excessive secretions, it can lead to significant difficulty for them in tolerating non-invasive ventilation. So again, it really impacts upon the care that we can actually deliver here. Additionally, as well too, unfortunately recently we've seen a few patients who have whose airways are very, very sensitive, and as soon as they get any sort of buildup of secretions, they start to go into laryngospasm, which is incredibly distressing for the patients, and obviously a life-threatening situation as well too. So if you do notice patients are starting to have produced more and more saliva and they're struggling to do that, it is around this active management of that siluria. So from a medical point of view, it would be liaising with the GPs or the specialist centres to try and get, or the palliative care teams to try and get appropriate medication used. The first line recommendation of medication, as recommended by NG42, is the Savanti-muscarinic, so hyoscine, atropine drops sublingually, and glycopyrrolate. And they do recommend glycopyrrolate more so in patients who have cognitive dysfunction, because it crosses the blood-brain barrier less easily, so therefore there's less impact upon neurological function here. In really severe cases, we've used glycopyrrolate subcutaneously with our motor neuron disease patients that have really significant issues with oral secretion management, and we've exhausted all the lines of treatment, and that has worked quite well for quite a few patients, but obviously it comes with other problems as well. Botox is the next line of treatment to the salivary glands, as I'm sure you're familiar with. We have just recently introduced a Botox Clinic for motor neuron disease patients only at Wythenshawe Hospital, and we are accepting patients who are under our service for non-invasive ventilation for Botox therapy. It's in its infancy at the moment, that clinic. It's only been going for about 3 or 4 months, but it is progressively getting larger, and we are having good results from that. We don't have any experience myself, but I know I believe Salford Royal do have this of patients who've had radiotherapy to the salivary glands when they've had really significant issues with management of hypersalivation. but they've then struggled with all of the medication management. So that is obviously extreme end of the scale, but it is always a possibility if you've exhausted all of the medication management and nothing else is working for these patients. From a community point of view, suction machines are quite a contentious issue. I know that it does vary from place to place in terms of the provision of suction machines. Unfortunately, as a service, we don't have the ability to issue suction machines to our patients unless in exceptional circumstances. We're not commissioned for suction. It is something in the future I'm wanting to try and get a service commissioned to provide suction machines for patients only who are under our service. But at the moment it isn't something that we offer, and depending upon which area it is, it's very much a postcode lottery. We can access suction machines very easily in some areas, whereas in other areas it's much more difficult. Previously we used to be able to access the Motor Neurone Disease Association, but I think they've had difficulty in supplying those machines recently. I may be wrong on that, but certainly from our experience recently, they haven't been as readily available through the MNDA. So this is an area. So if this is something you can source for your patients locally, that would be fantastic help for them, because as I say, it's something that's not very easy to access from ourselves. I think the key thing really is in terms of when we've got patients who've got sialorrhea is around this identification really, and onward referral onto appropriate services, whether they be GPs, regional services or the palliative care teams. And from a community perspective, that's really what we're going to ask of you here. So I'm going to move on to the management of cough now in the second half of the presentation. So just before we go on, what I would like you to think about is the components that are required to facilitate a cough. So I'd just like you to pause for a second, and if you are socially distanced in the world of COVID, just pause for a second and just have a cough for me. Might sound really stupid, but just try and cough for us now. I'll give you a second or two to do that. Apologies, I've got a cat in the background if you're wondering what the noise is. So when we think about what components are required to facilitate a cough, I like to think about these three different phases. So when you cough, we have an inspiratory phase. So that relies upon our inspiratory muscles, so our diaphragm and our intercostal muscles and potentially our accessory muscles, to be able to draw air into our lungs effectively. So we need a clear pathway for the air to go into our lungs, and we need good muscle function to be able to get the air in effectively. We need to get the air in to be able to provide that driving force of air to get the air behind the secretions and be able to generate enough air to come out. So that's what I term the inspiratory phase. We have a bulbar and an expiratory phase, which are really quite closely interlinked. So during the bulbar phase, as I like to term it, the glottis closes over our trachea, and then it relies upon our abdominal muscles and our internal intercostals to contract, and that increases the pressure within the thorax, what we would term the interthoracic pressure. Within a matter of milliseconds, we then get this expulsive opening of the glottis, and the expiratory muscles force the air out of our lungs in a cough. So it really relies upon this coordination, effective coordination of the bulbar and expiratory phases to be able to cough and clear effectively, coupled together with the fact that we need to be able to get a deep enough breath in. So these are all the factors that happen within milliseconds of you coughing, so that you obviously don't even realise what's happening here. Just controlling that, if a patient spontaneously coughs for themselves, then it's a reflex reaction. If, however, you say to a patient, can you cough for me? You're asking them to process something, process the fact you want them to cough. So actually it relies upon effective cognitive function here. And if we haven't got that cognitive function, no matter what you do to the patient, you're not going to be able to ask them to cough. They may still be able to cough spontaneously, but they won't be able to cough to command, unfortunately, here. So there is that degree of cognitive control potentially with coughing. When we apply that to motor neuron disease, if we think about, we may well get respiratory muscle weakness in motor neuron disease. So this will reduce the driving force, the amount of air that we can get into our lungs. So if we can't get enough air in, we're never going to be able to get enough air out. Coupled together with that is we may all get some biomechanical changes to the chest wall. So our chest wall, because we're not breathing as deeply, it can become quite stiff and not very compliant. So even if you're trying to get air in, you can't physically move the chest wall because it's so stiff. Frequently, when we've got some bulbar dysfunction, it's going to affect the ability of the glottis to close over the trachea. So coupled together with the fact that the abdominals or respiratory muscles may well be quite weak as well too, we're never going to be able to generate enough pressure within the thorax to force the air out. So all of these factors together promote an ineffective cough effort in patients with motor neuron disease. And these are the reasons as to why patients with MND are at risk of impaired cough effort here. We've also got, coupled together with that, potentially, if we've got some bulbar dysfunction, we've got pooling of secretions within the pharynx, which then, as I mentioned earlier, is going to lead to that increased risk of aspiration as well too. So what can you do in terms of assessing cough function? One of the key things really is around subjective history taking. So speak to the patient, as I mentioned before, speak to their relatives, speak to their carers. Have they reported that they're having more and more chest infections, or have they said, look, I've just started some antibiotics because I've got a chest infection? Or do you know what, I wake up in the morning, I feel like I'm really struggling to clear secretions and I have to cough and cough and cough and cough to try and get something up? Are they saying, actually, do you know what, I'm struggling with aspiration, I feel like that I can't manage my oral secretions? These are all sort of subjective markers that you can get for the patient that you get without even realising, and actually might start to make you think, do you know what, this patient may well be at risk of having some problems from an inability to cough effectively. Objectively, one of the key markers that we assess is something called cough peak flow. So that is effectively, it is the patient's cough strength, so how strong their cough effort is, and I'll talk to you about how we measure that in a moment. But it's measured in litres, and for us to be able to clear secretions effectively from our upper airway, we need to have a cough peak flow of at least 160 litres. That's to be able to clear secretions from the central airways. Anything less than 160 litres means that it's unlikely we'll be able to clear secretions effectively. So when we're assessing for cough peak flow, if we get a reading of less than 160 litres, it will give us an idea that potentially the patient is going to need assessment for some form of cough augmentation therapy to be using long term at home. We also look at a figure between 160 and 270 litres. And the reason why we look at that figure is that potentially patients become acutely unwell, or if they do get a chest infection, it's likely that their cough effort will also decompensate as other body systems would do. So for example, their swallow might deteriorate at that point as well. So actually we might say that a patient who's got a cough peak flow of between 160 to 270 litres potentially does need an assessment for some form of cough augmentation therapy as well. And that's certainly the guidelines that we follow up with Insure as well, and what's followed nationally here. You may not be able to do a cough peak flow assessment in the community, so thinking about some other things that you can look for, look at your patient. So can you ask them to cough? Can they cough? Does it sound like the cough effort's really, really poor and ineffective? So you're using that judgment to say, actually, do you know what, I can't objectively measure what the cough strength is, but it sounds like the cough effort's weak. So it's likely that they're probably not going to be able to clear secretions effectively. Look at how they appear to you. Does their breathing look quite shallow? Does it look like they're breathing quite quickly, perhaps, maybe, which is going to give you an idea that potentially, yeah, they're going to struggle to clear secretions, maybe, if they have got secretions there. If you're trained in auscultation, can you listen to their chest? Do you hear any added sounds? Does it sound quite quiet in the bases of the lungs as well too? Again, these are also ideas that potentially that there's some degree of respiratory dysfunction here, which is likely to impact upon the patient's ability to cough and clear secretions effectively. So it's not necessarily about doing really lots and lots of complex interventions. It's around looking at your patient physically, looking to see what they present like, getting their subjective history from them. Have they had evidence that they're aspirating? Is there evidence that their cough effort is weaker than it used to be? So I mentioned around the cough peak flow assessment, and this is something that we would do with Insure, and obviously I know a lot of you guys already do this in the community, but we use one of these devices, which is a peak flow meter. Simple peak flow meter that you would use to measure peak flows. The difference with this is we attach a face mask onto the end of here. There's a video which I'll play to you in a moment, which demonstrates the technique for it. But what we do here is attach the face mask on the end and we ask the patient to take a really deep breath in. The mask is attached over the nose and mouth, and the patient is asked to cough into that peak flow meter. And we get a reading here. So 160 would be here, 270 would be there, and obviously this, if it was 400, it would be there. Generally, if you've got a normal strength cough effort, you would expect to get a cough peak flow in excess of 300 litres. You probably would be a lot higher than that. But obviously, a patient who was at risk, it would be between either 270 and 160, or definitely less than 160 would mean they need some form of cough augmentation. If you don't have access to face masks, what you can do is that if your patient can make a seal, you can ask them to take a deep breath in, seal that mouthpiece into the mouth and cough into it as well. It's just often not quite as effective as it would be with a face mask though. So I'm just going to share my the videos with you. Hopefully this should work now. Let me just go back onto here. Let's just go into that. Okay, so I'll just upload this now.
To demonstrate that I'm being a carer and the person at the same time. So the carer will just support the back of your head because it's just easier to get that seal around the mask if someone's pushing that way and the carer is also pushing it on your face. The type of mask to get, which we can give details of later, are that they're quite padded around here, but you do need to push the mask on very firmly onto the face to get a good seal, otherwise the air goes sideways out the mouth. So the carer will put a hand on the back of your head. You'll be sitting upright, supported, your back supported in a chair or a wheelchair, and then the mask goes firmly on your face. You take a deep breath in, and then the mask goes firmly on your face, and then you cough. So I'm just going to demonstrate without the words now. So okay,
so you can see a nice sort of demonstration there of how we assess a cough peak flow there. Okay, I'm just going to reshare the presentation now. Just bear with me 1 second. Sorry. Okay. Sorry, I'll just take a second or two. So thinking about early management strategies that we can implement to improve a patient's cough function, something that's a really nice intervention that we can do is called unassisted breath stacking. Now, certainly this is something that the physios at the MND Centre at Salford Royal, they teach the patients when they first come to see them, but it's something that perhaps maybe they haven't had a chance to see the physios yet, and actually you might be seeing these patients in the community after they've just received the diagnosis, or it might be something that you just again reiterate to the patients and emphasise. Is this unassisted breath stacking, and it's a really simple way to improve a patient's cough effort. The overall aim is to try and stack a series of breaths on top of the other to allow one big breath to be taken in effectively. So if we get more air into our lungs, we can then get more air out. So it's going to improve our overall cough effort. And this helps to, as I say, to improve the overall cough effort. So a typical exercise will be for the patient to breathe in slowly through their nose and pause without exhaling. You then ask them to take another small breath in and pause again without exhaling, and repeat one more time and take one further small breath in, pause, and then have a cough. So I'm just going to demonstrate this to you on, I found a good YouTube video here. Now this is actually on a, sorry, just excuse me 1 second. This is actually done on a young man with DMD. His mum is a physiotherapist. So I'm just going to share this screen again for you. Okay.
Don't have a cough assist machine, these breath stacking techniques can help create enough pressure to produce a bigger cough. So if you don't have a cough assist machine, you can do the breath stacking techniques and produce a cough at the end. So I'll have Garrett show you guys that. So let's do the breath stacks, and instead of blowing it out, I want you to produce a really hard cough, okay? Ready? Okay.
See, it's a really simple way of just promoting the breath stacks and helping to clear secretions effectively. Okay, I will just let me reshare here. Okay, I'm not going to go into presentation because we have got another video to show there. So another means of helping to improve a patient's cough effort is if they can no longer do assisted breath stacking, or assisted breath stacking isn't effective, unassisted breath stacking isn't effective for them, we can move on to assisted breath stacking using this device, which is called the lung volume recruitment bag. So it consists of this little chamber here, which is very similar to an ambu bag that we would use on a resus trolley. The key difference is that that ambu bag is attached onto this piece of equipment here. So we've got a connector piece, and we've got this little valve here, which is a one-way valve, and that allows air to be pushed in. The valve opens on the breath in, but as the patient breathes out, the valve closes over and it stops the air from going back into the bag. That's attached to a catheter mount, which then attaches onto either a mouthpiece or a face mask that you can see here. The mouthpiece, what we would do is, if we were asking a patient to use a lung volume recruitment bag with a mouthpiece, we would ask them to put the nose clip over their nose and and the mouthpiece goes into the mouth itself. What we do is we ask the patient to take a breath in, and just a small breath in, and as they take the breath in, we supplement their breathing by squeezing this bag, which helps to push some air into their lungs. We then ask them to do the same again, so take a small breath in, and we squeeze the bag and the air goes in. Because there's a one-way valve, the air can't escape, so the patient then starts to breath stack. And if we can do, we might ask them to repeat that one more time. So again, they take a breath in, at the same time, we squeeze the bag, more air goes into their lungs. They then pause for a second before having a cough. We can do exactly the same thing with a face mask if they struggle to make an effective seal with their mouth using a mouthpiece. So this is a really, really effective way actually of improving a patient's cough effort by giving them a bigger driving force of air into their lungs. So like I said before, if you get more air into your lungs, you can then get more air out of your lungs. One of the downsides to this though is patients can use this independently if they can either hold the mask on themselves or put the mouthpiece in their mouth themselves and squeeze the bag at the same time. But obviously as patients become more debilitated, they may not necessarily be able to do that anymore. So it does rely upon them having a carer or a family member doing it. And sometimes the difficulty can be here, it's the coordination between the patient taking the breath in and the carer or family member squeezing the bag. So we can sometimes have a little bit of fun when whilst they're getting used to doing that together. But it can work very effectively, and a real bonus of this is it is quite inexpensive in the grand scheme of things. They're around about £20 to £25 per kit. Brias, who are one of the ventilator manufacturers, they actually assemble all of this equipment, and you can buy it directly through them. So it is another option as well too here. So I'm just going to share with you now a video from the North West Ventilation Service, which demonstrates the use of a lung volume recruitment bag for those of you that might not be familiar with it. Apologies, I'm pressing the wrong tab. That's it. Okay, so I'll just click on this one now. So on the North West Ventilation Unit website, we do have a number of training videos for different pieces of equipment. We are in the process of getting more uploaded. At the moment, we have one of the ventilators and the cough assist and LVR bag. So they are free to access for anybody that is interested in those.
Hello, my name's Gemma Price. I'm one of the specialist physios here at the North West Ventilation Unit. Today I'm going to talk to you about the lung volume recruitment bag, also referred to as the LVRB. Lung volume recruitment bag is a simple piece of equipment that may be chosen by your physiotherapist to help you improve your cough. It is composed of a squeezy green bag, a series of connectors, a one-way valve, and a long flexible tube. The bag can be used with either a face mask or a nose clip with a mouthpiece, depending on which is most comfortable and appropriate for you. After assessment, your physiotherapist may choose to use the lung volume recruitment bag to help you to take a bigger breath. When you're unable to cough, this can sometimes be due to the inability to take a series or one big breath. The lung volume recruitment bag will be used to give you a series of breaths, one after the other, to give you in total one large breath, which will help to make your cough stronger. We'll now demonstrate the lung volume recruitment bag with Katie using a face mask. Depending on the function of your upper limbs, you're able to either hold the face mask yourself, or your physiotherapist can train your carer or family members to do so. I'm now going to ask Katie to place the mask over her face. Once she's got a good seal, begin to take a series of smaller breaths to equal to one large breath. So Katie, can you place the mask on your face? After I ask Katie to take a breath in, I'm going to squeeze the bag to supplement her breath. Take a breath in for me, Katie. And again. One more. And if you take the mask off and have a good cough. Now going to demonstrate the LVRB using a mouthpiece and a nose clip. You'll be asked to place the nose clip on your nose, or your carer can do this for you if required. You'll then be asked to place the mouthpiece into your mouth and form a tight seal. Sometimes biting on the mouthpiece to create this seal can help. The technique will then be the same as it was for the face mask. You'll be asked to take a small breath in, another breath, and one more breath. Then remove the mouthpiece from your mouth and have a cough. If you have any questions.
Okay, so that is just a demonstration of the lung volume recruitment bag there. I'm just going to reshare the presentation now. So in terms of any sort of further or ongoing management of cough function, manually assisted coughing is another technique which can be useful for motor neuron disease patients. If this is something that you're familiar with and you feel confident in teaching, then you absolutely, you can teach patients, relatives or carers to do manually assisted coughing, and that can be effective in improving patients' cough effort. If that isn't something that you're confident with or feel happy teaching to relatives or carers, then obviously that isn't something you have to do. If you're in doubt or you're not sure, you've exhausted all the options that you can do in the community, you are more than welcome to refer on to the North West Ventilation Service. Our email address is here. You can email that address and they will send over a referral form for you to complete and send back over. Our gold standard is to review patients with motor neuron disease who need cough augmentation. We aim to review them within 1 to 2 weeks of having received a referral. With COVID, it has been slightly longer, as with many things really. Unfortunately, that's been related to the fact that we haven't been able to run face-to-face clinics, so we've been having to bring patients in for cough augmentation therapy in as a day case to our unit. But come the new year, we are reintroducing our face-to-face cough augmentation clinics, so we will aim to achieve that gold standard. With Ensure, we're able to provide a whole variety of different cough augmentation interventions. So, for example, we obviously have lung volume recruitment bags. We have access to cough assist as well too, which we commonly issue, as I'm sure you're all aware. We also can access the vest, the high frequency chest wall oscillator. It's not something that we use lots of, but we have had a small handful of patients with MND that have had a vest in addition to the cough assist. That isn't funded at the moment, so we do have to request an individual funding request from patient CCGs, but generally those have been approved. But we also can access non-invasive ventilation for secretion clearance, whether that be to do breath stacking with mouthpiece ventilation or to promote just general chest clearance. We can access those devices as well too very readily. Predominantly, we see patients for cough augmentation who have got motor neuron disease, muscular dystrophy, and myotonic dystrophy and spinal cord injuries. We do accept referrals for patients who have got other conditions such as Parkinson's, MS and MSA. They aren't our core cohort of patients though, so we obviously assess them on an individual basis to see if cough augmentation therapy is appropriate for them, as opposed to our core cohort of MND patients and muscular dystrophies and myotonics and spinal injuries, as I mentioned previously. So that is the end of the presentation. Thank you for listening to me. Unfortunately, I can't be there in person to answer any questions that you have directly, but please do feel free to email me. My email address is david.derry, DERRY, @mft, so Mike Foxtrot Tango .nhs.uk. Unfortunately, I can't respond to emails immediately just because of clinical pressures, but I will do my best to respond to you as quickly as I can. Again, thank you very much for listening and enjoy the rest of the sessions.
Okay, so hi everyone. So today we're going to talk about nutrition and swallowing management in motor neuron disease. My name is Sophie Gordon. I am a speech and language therapist in Salford CNRT and also at the MND Care Centre.
And my name is Christina Federico. I'm one of the neurodieticians at Salford, and as part of my role work with Sophie in the MND Care Centre.
So the outline of this session is to introduce the role of the dietitian and the speech therapist at the MND Care Centre, talk about nutritional issues, swallowing assessment and management, the nutritional assessment and management, specifically for patients with MND, and then look at gastrostomy, oral risk feeding, and just a quick update about voice banking as well. So as a bit of an introduction to what we do at the clinic at the MND Care Centre for Greater Manchester. So the aim is for all of our newly diagnosed patients to return to the multidisciplinary clinic for assessment. So the clinics run twice a month, and the patients with MND would have received their diagnosis on their initial clinic visit and then come back to meet the multidisciplinary team. So we have a joint speech therapy and dietitian consultation, and within that we would take a diet history and a nutritional assessment. We'd carry out a swallow assessment. We'd talk specifically after the assessment about dietary and swallowing advice. We could then talk about gastrostomy education, communication assessment and advice, which would include introducing them to voice banking, and then we would complete appropriate referrals or hand over to community teams. So specifically, sort of the benefit of having the speech and language therapist and dietitian working within the MND Care Centre is that we get a mix of patients. So some might already be known to their local teams if they have, had symptoms for quite some time before their diagnosis, or they may be completely new to speech therapy and dietetics. So the NICE guidelines for MND specifically talk about having an assessment from a speech and language therapist without delay, and kind of specify that care should be coordinated, and that difficult conversations shouldn't have to happen multiple times if they're not required. And at each review, their weight, nutrition and fluid intake, feeding and swallowing status is all reviewed. It's a full MDT clinic, so often the patient's consultant is sort of available or present, specialist nurses, and there's occupational therapy and physiotherapy as well, alongside research nurses, so that kind of coordinated care is available. The swallow assessment, 2/3 of all patients diagnosed with MND experience dysphagia for different reasons, so this is able to provide a baseline or monitor for change. The nutritional assessment and advice is often that first line advice to kind of start the patient off with. The joint assessment is really useful for talking about early PEG discussions when we know sort of what their swallowing baseline is like at that time. It's kind of time for a brief communication assessment, so we can give them advice as they need it, including voice banking. So obviously we'd want that to be as soon as possible, preferably before they have any difficulties with their speech. So that new patient appointment is really useful for introducing that as soon as possible. Okay, so thinking then initially just about kind of the swallowing and patients with MND, kind of those signs of early dysphagia. So sometimes they'll already come to looking for a diagnosis because they have difficulties with their swallowing already. And it's just really useful for the whole MDT who might see that patient or come across that patient to be able to identify some of those things that might indicate they have a difficulty with their swallowing. So some of those signs of early dysphagia or eating and drinking difficulties might be really, really common knowledge for speech therapists who are working with any population, really, adult population, but some things that we might not always consider. So thinking about, can they actually feed themselves? So their arm and hand function. Have they had any unintentional weight loss? Thinking about their breathing and cough changes at rest, prior to eating and drinking, at baseline, and as well when they're obviously eating and drinking. Food remaining in their mouth after eating, so pocketing and more residue, difficulty chewing, food and drink sometimes reporting that's getting stuck. Obviously the obvious one that's quite sometimes quite distressing that the patient might report is coughing and choking after they're swallowing. Voice changes, so if you notice their voice sounds quite wet or quite gurgly, particularly when they're eating and drinking. Changes to their breathing, so they might seem sort of fine at rest, but then have difficulty sort of when they're eating and drinking. Obviously, we often look out for recurrent chest infections. We'd hope to kind of be aware before we get these recurrent chest infections. Kind of difficulties managing their own secretions. So if they're starting to drool or dribble, or they feel like they've got excessive saliva, a lot of the time it's not more saliva, it's just thin and they're losing control of it in their mouth. So it suggests that their muscles aren't working as well as before. And a loss of appetite, so some of that is medication, multiple potential causes for it, and taking a long time to eat their meals. So obviously another thing to look out for that sometimes alerts people to the fact that there's something changing is their speech, so that kind of bulbar sounding speech. So either bulbar palsy or pseudo-bulbar palsy. So your bulbar palsy would be your lower motor neuron involvement. Your pseudo-bulbar palsy would be upper motor neurons, but there could be a mix of both. And often, especially initially, you might find a disparity between how significant you feel their dysarthria or their speech is and how it affects their swallowing. So you might find somebody with quite a clear dysarthria, but actually their swallowing is kind of maintaining and seems to be okay at the moment. So it's just keeping an eye on the link between their speech and their swallowing. And also their voice. So sometimes that kind of hoarse, strained voice quality sometimes is one of the first things to alert you to the fact that somebody has changes, bulbar changes with their MND. So just some points, I suppose, as to why MND patients might be different in terms of the adult population, in terms of their swallowing. You want to consider the holistic view and obviously that trajectory. So, we know that they are degenerative, so things will be progressing and changing, as opposed to in other conditions where things might stay stable or improve. We might want to think about things like, that things are potentially going to get worse and progress. So in terms of chin tuck postures, compensatory strategies, the evidence around this is really conflicting at times. And so we would only really recommend this sort of thing if we can check that it actually benefits the patient on video fluoroscopy. You know, there often can be sort of silent aspiration and difficulties with changes to sensation. So if that is suspected, then obviously a video fluoroscopy would be indicated for these patients. Things like chin tuck can make people swallow worse and increase their risk of aspiration as well. So we would want to check that with an objective assessment before recommending it. We'll talk about this a little bit more, but the PEG discussions are often talked about before the swallow function is actually largely impaired, and that can be quite a change to other kind of dysphagia assessments and management. And consideration of respiratory and cough function. This is very common in our patients with MND and can rapidly change. So where we might see a patient with COPD that's really well managed, we would expect that even if they don't initially have a difficulty with their breathing or their cough, that patient might then you know, start to have those difficulties as the time goes on, and obviously that can really impact on their speech and their swallowing ability. And then thinking about acute versus community. So do they have wishes in place before we go and put them nil by mouth? Have they already decided they want to risk feed, for example? And making sure those wishes and those difficult conversations that you've already had are communicated so that they're acted upon in the hospital if they do have to be admitted.
So following on from what Sophie's gone through, just to talk a bit about nutritional issues in more detail. Obviously Sophie's overview of bulbar weakness and issues with swallowing and saliva management has explained why nutrition would be an issue for an MND patient experiencing those symptoms, but just some additional things to be aware of that can impact upon nutritional status. So we have evidence to support that people with MND have a higher calorie requirement, so needing a higher amount of energy from their diet, and this is what we refer to as hypermetabolism. And we don't fully understand why this is happening. It's something that research is actively looking into, but I guess no two patients are the same, but we know likely that a patient could be eating and drinking well but still have a higher calorie need. There can be added things that in addition to that affect their calorie requirement, but as a baseline, anyone with MND, we should be aware, has that higher energy requirement. There are obviously some functional symptoms, as Sophie has already mentioned, that can affect eating and drinking. So if the upper limbs are affected and the patient is struggling to perhaps prepare or feed themselves or take adequate fluid. Respiratory insufficiency. So kind of two perspectives to this, that as the patient is starting to develop respiratory symptoms, we know one of the common side effects can be that their appetite goes off as they're feeling more breathless or fatigued, having more naps through the day. They're then missing meals, and if it does then lead to a patient being established on non-invasive ventilation, we then can often see a bit of a bounce back with their nutrition where they do better, but then as that respiratory insufficiency deteriorates, then they need the NIV even more. So perhaps initially they just start overnight and then they have it for periods during the day. It's incredibly difficult to take adequate amounts of food and drink orally if you have the mask on through the day as well as at night. Fatigue for many reasons, so we know it's a very common thing that people with MND report, and that again that can change. So if it's somebody that's been used to having their main meal in the evening but they're really tired by that time, so whether they're bulbar or not bulbar, these are the subtle little things that can affect really how they eat and drink during the day compared to their baseline. Things like cognitive impairment. So we know there are a proportion of patients with MND that have frontal temporal lobe dementia. Again, because of some of the symptoms involved in that, it can affect the way that they eat and drink, particularly if they become more disinhibited and can have dietary changes. Psychological symptoms like depression and anxiety can have a massive effect on all areas of life, but again, it can have a knock-on effect on appetite and diet. And then connected to some of those physical symptoms, whether it is a bulbar difficulty or a physical difficulty with eating, we often hear from people who come to the clinic that they feel quite embarrassed when eating. And so a social consequence can be that there's less eating out or eating with friends and family. And then other side effects of physical symptoms that, again, people have reported to us is that because of change in physical activity, they may be more prone to constipation. And so that impacts the way that they eat and drink and the dietary choices that they make. And then again, if there is physical impairment and it's quite difficult for the patient to go to the toilet and they're perhaps waiting for carer visits, we have heard again from people that they alter the way that they eat and drink to kind of avoid having to have that toilet trip until they have the support to do so. So lots of different reasons to summarise really why nutrition is a concern and an issue for people with MND. Specifically what we look at when we conduct a nutritional assessment when a patient comes to clinic, and what we would recommend for anybody undertaking a nutritional assessment for an MND patient in the community, is first of all to look at detailed weight history. So we'll come on to in a minute of the evidence that we have about weight and why it's so important for us to look at weight history for somebody with MND. But the terminology that we tend to work in is percentage weight loss. So to calculate that, it's the baseline weight minus the current weight divided by the baseline weight times 100. And what we really want to hone in on is what the weight loss has been since the diagnosis and then ongoing after that diagnosis. We conduct a really detailed diet history and nutritional intake assessment, and we don't just ask the person what they're eating and drinking, but also how they're eating and drinking. So this ties into what Sophie was saying about some of the symptoms, how long it's taking somebody to eat and drink, and foods that they may have cut out or fluids that they're no longer having, if there's kind of any loss, so like fluid loss, or if they are having to have like half meals. So again, we hear from some people that the meal may have gone cold by the time that they can finish it, so it's affected how they eat and drink. We try and get an up-to-date assessment on their symptoms. So obviously the patients that we see that tend to be struggling most with their nutrition are those that have bulbar dysfunction. So it's really getting a detailed history, because as Sophie mentioned, it will degenerate. So each time they're reviewed, we want to know if there's been any changes, and so to get that feedback from the patient. And I think just to be aware, because it is a condition that worsens, any kind of red flags or symptoms of disease progression, so they would be things that we factor into our nutritional assessment. So we have the benefit of being part of the MDT and have access to up-to-date information. So if we are able to find out if they've started to have some respiratory symptoms, that would be a red flag that we'd apply to our nutritional assessment, that they may be eating and drinking well on that particular day, but we know that things are heading in a certain direction. So kind of the main things that we get more information about in detail, in addition to their diet history, is the fluid intake, so how much they're having, how they're drinking, how it compares to baseline. Texture of the diet, which is the benefit of a dietitian and speech therapist working together in the clinic. Obviously, if a dietitian is going out in the community and seeing somebody without the speech therapist, it's making sure that we're really up to date with what the speech therapist has recommended. The way in which the individual is eating, consistency more in how consistent is it. So again, we might meet them on a day that's particularly good, but it's really getting that history, because fatigue can be such a big thing that can affect how consistent the eating and drinking pattern is, and to really hone in on any respiratory symptoms, so to be aware of that and aware of what their treatment plan is with regards to management of that. And just to summarise, with all of those things, we want to really compare back to baseline, particularly for a new patient, of what changes have occurred. So the key points are, it's not just what do you eat and drink, but how long is it taking you? How much are you actually eating and drinking? How much has this changed, and how does it compare to before your symptoms began? And I think that's the other important thing, is that somebody might have been having symptoms for several months, if not over a year, to them actually getting the diagnosis. And how much effort is going into managing their eating and drinking. So we could have a patient that's maintaining the weight, and on paper it looks like they're eating and drinking well. But when we dig a bit deeper and find out more, we realise it's incredibly effortful for that patient to maintain, and it's a lot of effort going in on a daily basis. So coming on to the weight, and I mentioned that obviously is one of the first components of our nutritional assessment and why it's so important, particularly for MND. And I think just to give some history, is there has in the past been a view that because it is a muscle wasting disease, that some weight loss is unavoidable, and there's still a lot that we don't know, as I said, about metabolism and weight changes. But what we do know from the evidence is that weight loss and malnutrition are prognostic indicators, and BMI, which is the body mass index, is an independent predictor of survival. So the research is telling us that patients that have a greater than 5% weight loss at diagnosis have a twofold increase in the risk of death compared to those with less than 5% weight change. And then post-diagnosis, the evidence is showing that ongoing changes, so decline in BMI, have been shown to predict survival. And so if there's a slower decline and decrease in BMI, there's a better prognosis. In terms of weight and how this is often looked at in main kind of community dietetic teams outside of a community neuro team in Greater Manchester, we know a lot of teams will have a nutritional screening tool, and I think it's just to illustrate why an MND patient may not be picked up on a standard screening tool. So this is just an example of a screening tool called the Malnutrition Universal Screening Tool, which is shortened to MUST. And it's a 3-step process where step 1 looks at the body mass index and what's classed as healthy, underweight and overweight. Step 2 is this percentage weight loss, so the unplanned weight loss, but over a 3 to 6 month period. And step 3 is if there's been a reduction, an acute reduction in intake. So the 3 steps are added up together, and that generates a risk score. So the reason why somebody from MND may not score is they could first of all be a healthy body mass index, but again, all those things that we mentioned in previous slides, there could be a lot of issues that are affecting their nutrition. They're just working incredibly hard at maintaining a healthy BMI, and in fact could be maintaining their weight. Again, because a tool like this uses a short time period, like 3 to 6 months, we know for patients with MND, symptoms could have been happening for several months before diagnosis, so it's not really taking into account that level of detail. And obviously very few would probably score on the 3rd step, but clinical judgment will be used by teams. So if it's a bulbar MND, it's highly likely they would be listed for input from the dietitians. I think it's just to show why we couldn't rely on this, and that we have to refer to the evidence we have really about the nutritional issues and why we think this patient group are high nutritional risk. So in relation to weight and what we know about the weight changes, how do we then approach that in clinic, and what would our message be to people seeing MND patients in the community? So we have to make sure it's always covered and checked. So obviously that can be a challenge sometimes in the community in getting an up-to-date weight. Every time that a patient comes to clinic, they will have their weight checked, which tends to be roughly every 3 months. So we can link in with the care centre to get weight measurements if it's a challenge in the community. So we'll always discuss it and refer to any weight changes. And our message really is if a patient doesn't have significant issues, they're eating well, we don't want them to really lose weight. We want weight maintenance because of all the evidence we've got about BMI and slow changes in weight. If it's someone that we want to try and promote weight gain with, we will give the specific nutrition support messages, which I'll come on to. And because of all the evidence we have about the importance of weight, we want there to be a really proactive approach. So not to be kind of very casual and it's only the odd kilo. We want, to kind of guide patients and say, and this is what we tell all new patients, that be very responsive if there's been any form of weight change and it's going down. And obviously to be aware that can be for a non-MND reason. So they could have a tummy bug, a cold that could really knock their intake off. And that's where we'll give them some nutrition support messages to factor in and kind of apply those when they need to. The other things that we do in the clinic, in addition to kind of the nutrition support assessment and the weight messages that we give, is it's obviously an opportunity to meet an MND specialist dietitian. So again, we are in a beneficial position that because we're part of the MDT and we have access to some of the research trials that are happening, often there are people that are eating really well, but they may have quite a lot of questions about nutrition because it's an area that can be of a lot of interest to patients. And so we will always respond to those questions. And then it's not forgetting other conditions and comorbidities that patients with MND can have that can affect diet. So again, in the clinic, and we would obviously tailor that to the patient. So if it's someone that's really struggling with bulbar function and their intake, we aren't probably going to be too concerned about some of these other conditions. But again, we're there to provide advice, and it's kind of guiding the patient through how do they balance some of the previous advice they've been given for certain conditions versus the advice that we're given for MND. So in terms of the treatments offered that again would be in the clinic and we would say to continue in the community, is something called oral nutrition support, which is where we're trying to maximise the intake of the patient through mainly the use of calories because of all that evidence we have around the higher energy needs. So that's where we give tailored advice to the patient based on their diet assessment. But it is a patient group, just to say that we'd be really proactive in terms of using the nutritional supplement drinks. So there can be prescribing protocols now across Greater Manchester, which quite often ask for a dietetic assessment. But it is a group that we would say we wouldn't want to hold back, because we know which direction, again, things will head in if somebody's already having nutritional issues. It quite often can be we can stabilise someone, but we do need to be future planning. And something that we commonly do in the clinic is maybe introduce these products to the patients and give them some samples so they're aware of them, and should they need them, they then, you know, have tried which ones they like, the flavours, and it's something the community dietitian can then take on and review with them. Obviously, it tends to be other members of the MDT that would look at things like posture support and support with kind of the function of eating and drinking, but we obviously have access to that within the clinic, and again can be handed over. And by SALT being in the clinic, somebody like Sophie is able to give very specific dysphagia management advice. And then quite often jointly between the dietitian and speech therapist, we could pick up fluid management, because again, that's a really important part of our assessment. And then another common thing that can come up, perhaps connected to that area of discussing MND, nutrition and research, is that we have found there's been an increase in popularity of people using what we'd call alternative diets, so where they've gone on a particular diet or they've made certain changes with the view that it will aid their symptoms, or perhaps, you know, on very rare occasion that there is a curative hope with something in their diet. So obviously we will provide education to the patients on that, because there's no evidence to support any particular diet other than the tailored information for kind of swallowing difficulties and calories. But we'd always respect the patient's wishes. So I think it's understanding why they're doing that, just making sure it's not too limiting and it's really affecting both their nutritional intake, but their enjoyment of eating and drinking, and then they're not spending a fortune on things like supplements and certain products that aren't necessary. And then final kind of step that obviously can be quite detailed and a difficult discussion that we conduct in clinic is really around future planning. So for patients that are of high nutritional concern, particularly the bulbar MND patients, we'd then be looking at planning gastrostomy tube placement and discussion with them. So that takes us on to the next section. As Sophie mentioned, it is a patient group that's slightly different to other neurological conditions in terms of how we approach gastrostomy and the time frame and what we call the window of opportunity. So just to define that, it is recommended for longer term nutritional support for patients with MND, particularly those with severe dysphagia. And the European Federation of Neurological Societies had a criteria really of where gastrostomy should be considered. But we also have some up-to-date evidence from research conducted in the UK with a study called PROGAS that links to all this information we have about weight changes, that again advocates a more proactive approach to gastrostomy, because really we've seen that there are worse outcomes if there's a higher level of percentage weight loss from diagnosis. So just to give a bit more detail about what PROGAS found, it was a prospective multi-centre evaluation that looked at current care, kind of an intervention in terms of gastrostomies across 24 UK MND care centres, and there was over 300 patients included in the study with a 1-year follow-up. And the main thing to kind of take away in terms of why that 5% weight loss is used as a trigger is that they found that the patients that had greater than 10% weight loss prior to their tube insertion were 10.7 times more likely to die within a month after having that tube placed. And then another interesting statistic that they found was that half of patients with MND that have a gastrostomy went on to gain weight, so half didn't gain weight. So they've undergone a procedure to kind of deliver more nutrition, but it hasn't met the aim of increasing the weight. Obviously, just to add to this, PROGAS had quite specific focus within their study, but there are obviously, for comfort reasons, gastrostomy, it's not all about kind of weight and calories, in that for patients with swallowing difficulties, it can be an absolute useful lifeline in terms of fluid and medication, and then obviously getting some nutrition in, even though the data has shown us for some patients that wasn't necessarily enough. So just to summarise what we do in terms of how we approach gastrostomy, because the patients have seen the MND consultant before they see us, and because of the way that we're now working and that we're very proactive with approaching gastrostomy, if there is a bulbar MND patient, it's often that the MND consultant will have raised gastrostomy at the first appointment. What the MDC follow-up appointment allows us to do is pick that up. So the seed is sort of implanted for the patient to think about, and it can be a massive shock for many people, that discussion. And we can then have more detailed discussions and kind of talk about more of the practicalities and share what we come across as speech therapists and dietitians. So the key thing that's different about MND is early insertion of a gastrostomy and therefore early discussions. So this relates to the evidence we have about the weight change and the benefit of the gastrostomy, but also that we know there's this tight window of opportunity. And unfortunately with bulbar MND, as I've said, some patients could have had the disease for some time before actually receiving an official diagnosis. So what we want to avoid is that they're in a crisis situation and that gastrostomy is needed quite urgently. We want it to be done in a planned way, and we want it to be done when they're fit enough to have this procedure. And so that can be a really, really difficult conversation to have with patients. And I think particularly if they're not having any current difficulties or they're managing quite well, as I said, it comes as a massive shock. So there's a huge role for gastrostomy counselling really and talking through the specific evidence for this condition. Some other things to be aware of are that respiratory symptoms are also a huge trigger. So aside from the bulbar issues, if a patient is starting to go into respiratory failure, this is an indication for gastrostomy discussions. And that relates back to what I said earlier on, that as the disease progresses and the person is more reliant on the NIV, it obviously becomes incredibly difficult to eat and drink. And it's a patient that has more respiratory compromise. So again, it's getting them through that procedure when they can tolerate it. The thing that's worth being aware also is that for some patients, they may not be able to go on to have a PEG because deterioration can happen quite rapidly. As I've said, this window of opportunity actually does seem to be quite small for a lot of patients. And so just to be aware of that, I think in any wording that's used, discussions that are held with patients, that it's managing expectations and always making them aware it will be subject to them being fit for the procedure. And then just to be aware, and NICE has some guidance around this in terms of how we apply what we know about nutritional treatment plans and intervention in terms of gastrostomy to the FTD group. So it's not an absolute no that somebody with FTD in terms of having a gastrostomy, but it's obviously more complicated and quite often would have to go through a capacity and best interest process. So what we do to support the discussions in clinic that we found, I guess, some tips that are helpful and that definitely community teams currently are undertaking in addition to what we do. We will show the sample tube to the patient because I think it can just sound quite horrifying, the word tube, and quite often when they see it, it's not what they expected. It's very common that people feel it will be a bigger tube. So we try to give as much detail as possible about what's kind of involved in using the tube, including the daily care, and obviously we can assess if somebody may need to have support with the care of the tube. We feel it's important to acknowledge pros and cons, so we don't want to necessarily be salespeople for gastrostomy. It's about having that very open discussion to ensure that the patient is able to make an informed decision if gastrostomy is something they want to consider. And to be aware in relation to that some people may not wish to have, and they're very clear about that. And we'll come on to kind of what the options are if somebody decides not to have a gastrostomy or perhaps isn't fit for one. So just to share some of the comments that we get from patients, they can be quite surprised when they see the tube. There's a really common misconception that by us talking about a feeding tube, it means that eating and drinking is to stop. So there's lots of discussions around how initially it would likely be a supplementary route of feeding, nutrition and medication administration, and that it can in practice, what I found is that, early on in particular, patients can use it ad hoc. So there could be some days they use it more than others, particularly in relation to fatigue. And then the key thing that really, if we think back to all the evidence we've got around nutrition management, a very, very common piece of information that we hear or feedback from patients that aren't really sure about gastrostomy is, I'll think about it when I need it. And it's really getting that message across and conveying about how time's not really on our side in terms of making a decision, and again supporting the patient because of how difficult it is for them to get their head round kind of having this discussion. And I guess connected to that, we're in a clinic environment where we're discussing lots of different things, so really this is where we want further discussions to happen in the community. And in the future we would hope that we could have something like a nutrition clinic at Salford, but obviously we don't have that capacity at the moment. But if we're really struggling with someone in the community, it's kind of linking in with us as a care centre if we do need to bring somebody back, because we can bring them back to a consultant clinic and support and have further discussions if it's quite overwhelming. So things that might help are meeting other patients that have gastrostomy tubes and hearing about their experiences. As I've mentioned, actually physically seeing a tube, because it can be quite an alien concept to a lot of people. There are now quite a few online resources. So there's a study that's happening at the moment from the University of Southampton that is working on a decision-making aid that will hopefully then be widely available for patients to use. But if interested, there's a link included in our presentation. An active resource is something called MyTube, which came from the Sheffield MND Care Centre, which is a really helpful resource because it's MND specific, and it has patient videos, and that talks to patients both who decided not to have a gastrostomy tube, so it's real life experiences. And then again, some trusts will have their own gastrostomy specific booklets, but just to be aware that the Motor Neurone Disease Association have a very detailed booklet that talks about gastrostomy feeding, but is specific to MND. So it kind of talks in detail about some of the evidence that we have that could be of support to patients and their families. So if somebody isn't for a gastrostomy, both through choice or because they're not suitable, what are the options? It's quite rare, I would say, that somebody goes on to have a nasogastric tube. So just to be aware of the complications really in managing that in the community, which I think a lot of community dietitians will be aware of. But there are times it has come up for a discussion for certain patients. So it's not, again, an absolute no, but it's something that's quite tricky to manage. It really then might be more about supportive management, and then Sophie will talk a bit about risk feeding. But we really want good coordinated care and good communication, as Sophie mentioned, about what happens when swallow worsens and how do we manage that when somebody has an acute admission, because we have had experiences where we know somebody isn't eligible for a gastrostomy, they have an acute admission, they're put nil by mouth, have an NG, gastrostomy is discussed again by a different team. And then obviously there's a lot around nutrition and end of life care, because it is a condition where we should be thinking about the patient's wishes and factoring in nutrition, even if somebody has a gastrostomy tube, what their wishes are towards the end of life in terms of the use of that tube.
Okay, so following on from that, thinking about risk feeding. So again, it sort of can apply to a lot of patients. So not necessarily just the ones who don't want or aren't suitable for a gastrostomy, but those who already have one, but then their swallow has worsened to a point where they're kind of symptomatic of aspiration. So there should be a balance between kind of conversations around oral intake for pleasure, but that feeding can also be difficult to manage. So I think in a lot of those kind of early discussions around oral intake and versus gastrostomy, a lot of the patients feel like, you know, I want to carry on eating and drinking because I get a lot of pleasure from it. And obviously they do, and every patient is very, very different. But if they think about not having a gastrostomy for that reason, sometimes obviously it can become quite uncomfortable, potentially distressing, and very difficult for them to eat and drink as their swallow deteriorates. So I think it's just being careful to kind of make sure that they are aware of how that'll be, and it won't just be that they just eat and drink a little bit less. It could be that it becomes quite difficult and uncomfortable for them. So obviously, if they aren't able to have alternative feeding, then it is thinking about kind of risk feeding and what that will look like. So the Mdt involvement is really, really helpful at this point. So thinking about involving palliative care, especially with a bulbar patient where they're already dysphagic, they already have issues with their swallowing, we know that that's going to get worse. So if they haven't chosen to have the gastrostomy at that point, we're thinking about, you know, potentially joint home visits and joint working with nursing if possible, thinking about forward planning and making sure that we know what their wishes are. it is unlikely to just be their swallowing getting more difficult. So like Christina talked about, kind of those red flags being their respiratory function deteriorating, for example. So having somebody else that can look at that in a more holistic way, thinking about medications, for example, is really, really helpful in helping us kind of feel supported, having those discussions with the patient. And obviously their family. So a lot of the time the patient is just really keen to eat and drink, but their family might find that quite difficult. So supporting them in terms of how they feed, how they eat and drink, can be really, really important, and can help them feel a bit more confident. So it's not just about modified diet and fluids, it's obviously about their wishes and really tailoring everything to be specific to the patient. And in terms of posture management, cough assist, for example, and the use around that. So it's really thinking holistically to make things as supportive as possible. Capacity, so again, that frontotemporal dementia that can be, can be common in this population, or is noted in this population. Thinking about their capacity, so do they need support with communication to make those decisions? And alongside that, having really clear documentation and sharing of that information, so that if they do come into hospital for something connected or unrelated, or district nurses or a different team go in to see them at home, that all of those decisions that they've already made are nice and clear, so they don't have to keep having them.
So before we reach the conclusions, some key messages that we wanted to share, because as Sophie mentioned at the start, if there are speech therapists and dietitians watching the webinar, there'll be a lot of things that we've talked about that they will be aware of. But it's kind of top tips for if you aren't a dietitian or a speech therapist, what can you do as a member of the MDT when you're perhaps going to see the patient, and things to be aware of that could help in supporting management of nutrition and swallowing. So from a nutrition and kind of the dietetic perspective, key thing is to make sure weight monitoring is in place. So we have got the care centre reviews as a backup, but it'd be really helpful to have more regular monitoring happening in the community. It's really around mindset about weight. So as I said before, that we don't really want to view any weight loss as acceptable. It doesn't always mean it's achievable for us to reverse it or to increase somebody's weight, but to really have that quite proactive approach that we respond to the weight loss. Be aware of those subtle cues that can impact nutrition. So rather than wait until somebody is really struggling to kind of activate maybe a dietetic referral if they're not already under them, look at those early things. So pick up on the symptom changes, like the respiratory changes. If they're more fatigued, are they finishing their meals? Are there signs that things are starting to deteriorate? It's good, I think, for all team members to be aware of what has been discussed about gastrostomy and the specific advice for MND, particularly if you're seeing a mix of different patients. So the key thing is that we know there's a limited window of opportunity, and it really is something that requires specialist support and discussion, and so to be cautious really in how patients' expectations are managed. Final point to share is that I know there's varied dietetic support across Greater Manchester, but don't hesitate, even if there's limitations in your dietetic service locally, to refer an MND patient. So if you're starting to spot signs and you have concerns, make that referral. If the referral is rejected, or there is a limitation in what the local dietitians can do, or a long wait, then please do contact the care centre or consider kind of escalating locally. But we in particular would be keen to know about any issues that are being experienced.
So yeah, in a similar way, you might have a patient already who isn't necessarily for direct speech therapy input. They might have, no changes to their speech or swallowing that they're reporting, or that they're aware of. So because there's that potential for rapid change, and potentially for crisis situations, the whole MDT should monitor. So if a person with MND or suspected MND prior to their diagnosis is reporting any changes to their speech or their swallow, they just need a referral straight to the speech and language therapist for specialist assessment. Having support with positioning, the head position, neck braces, orthotics, adaptive cutlery can really, really help, especially in those kind of early stages. It's not necessarily about dysphagia, but those other things are really impacting on them. And just to be aware of voice banking, so again, there's that sort of window of opportunity. So if they have no SLT needs, could they have support to bank their voice before their communication changes? So if everyone's aware of that, to pick up on it and recommend it to the patient or discuss it with the patient, that's really helpful. Thinking about secretion management, so it's potentially a sign that their swallow is becoming more difficult. But in terms of their chest, medications, positioning, supporting with secretion management is really helpful. And being aware of and thinking about their oral care. So do they need to start to attend a specialist dentist? Non-foaming toothpastes, oral moisture gels, things like that, to prevent or reduce the risk of aspiration pneumonias if they're having difficulty with their saliva. So just really quickly, this is mainly sort of about obviously swallowing and nutrition, but in terms of voice banking, in case there are other people who don't know what it is, there are free webinars available. So Richard Cave runs these really regularly, and it's a really changing picture because obviously it's about technology. So the patient will record sentences. Some services do sort of 50, others do 50, 100. It takes a sample of their voice and basically generates a synthesized version of their voice for them to use later on if they need it with alternative communication device. So the earlier they do it, the better. We describe it sort of like an insurance policy. So I just wanted to kind of clarify that there are multiple languages available, so it isn't just in English, but you'd need to check with the software that you're going to use or the company you're going to use. There are always more being developed as well. If they are quite dysarthric already and their speech has already changed, you can use something like Speak Unique, who do voice repair service, who can actually be really, really effective. So don't just discount them if they have some level of dysarthria. Thinking about message banking, if they don't want to really do voice banking, encourage them just to record voice notes on their phone. So just personal messages to them, to friends or family, using people's names or phrases that are really personal to them, so that anyone can just do that, even prior to their diagnosis. Once they have the diagnosis, the MNDA fund it, but prior to that, you might want to start thinking about kind of just doing some informal voice notes on their own phone, for example. And check the technology they might want to use before you pick a service. So for example, Speak Unique, you have to use the app that they've developed, and it doesn't work on certain Samsung phones, for example. And it's quite upsetting when someone has banked their voice, their speech is then deteriorated, and you find they can't actually use it on their device. So really do check what it's compatible with before you do it. And then the other thing just to have a look at is the Euphonium Project. So Google are taking samples of people with dysarthric voices in order to make them more compatible with voice recognition technology, like Alexa, for example. So have a Google or email for more information if you need. But if you have any patients where they could provide a sample of their voice, that's also some research and some development that's going on. Okay, so just to conclude then, the MND population are a really complex patient group. They require early and regular intervention. So there's a really kind of a big role for this MDT approach to the management of nutrition and swallowing, and for the rest of the MDT to also monitor and keep, be aware of those issues. It's key to have regular communication, so both with the care centre team here at Salford and the Northwest Ventilation team as appropriate. So, both of us are really happy to be contacted to discuss the patient care, whether it's just to kind of run ideas past us or find out some more information. We have access to team MDTs and clinics, so we can provide sort of other information as well, to help with any management. So if there is anything that you do feel like you wanted to discuss, then getting in touch with us is really important.